It is really a pleasure for Child Family Health International, the Highland Support Project, and the collaborative for, the Community-Based Global Learning Collaborative to be able to bring you this presentation. I wanted to first make a note on language. I will make this note in English and request that Gonzalo does so in Spanish. So today's webinar will be recorded. It will also be translated simultaneously. And in order to hear in your preferred language, you need to go to your Zoom panel and select the language that you prefer. Interpretation is being provided by Pamela, and we're so grateful. Gonzalo, would you mind providing those instructions in Spanish?
Good evening and afternoon, everyone. Welcome to this webinar. The important part is that this webinar is going to be provided both in English and in Spanish. We've got a translator today. It's Pamela, and she's going to be helping us with the translation. So at the bottom part of your screens, you're going to see at the right side, you're going to see a small icon that says interpretation. There you just click on it, and there you will be choosing the language of your preference. You can speak in Spanish or in English, and we're going to be listening in the opposite language. Thank you.
See?
So we can speak in Spanish without expecting for the translation, right?
Yes, perfect.
Yes. Okay, simultaneously. Thank you.
No, you're good. So for those of you attending, you will hear in your preferred language simultaneously, and Pamela will interpret. We will have a Q&A and discussion section, so please use the Q&A function, and thank you, Mike, for monitoring that. Before we get started, I want to do some really key introductions, not only of our panelists, but the organizations that are bringing this to you today. Child Family Health International is a nonprofit based in the California Bay Area that's been around for 33 years now, providing global health immersion programs throughout low and middle income countries. Our tagline is "Let the world change you," and I hope that the meaning of that comes through today. Gonzalo, Susana, and I are all affiliated with Child Family Health International, but we have the privilege to be speaking on behalf of a huge global team who works day in and day out to provide well-adjusted and decolonized global health experiences for undergraduate, graduate, and postgraduate students. Mike, could you tell us a bit about the collaborative? Thanks so much, Mike. And Ben, could you tell us about Highland Partners a little bit more?
Great, yes. So Highland Support Project, our organization, we are talking about Highlands, but Highlands not necessarily as a geographical descriptor, but rather a social structure, looking at the process of settler colonialism, the notion that it's not an event, it's a process and it's ongoing. So as an organization, we are critically questioning how do we as NGOs, academics, agencies, how are we perpetuating the dynamics that maintain highland indigenous communities in certain social conditions with predictable indicators? So we're much more interested in analyzing and transforming the dominant system that has perpetuated harms to indigenous communities. And so then how do we interpret, adjust, and develop programming for cross-cultural, pluriversal engagements with indigenous communities that's culturally appropriate for those communities? Thank you.
Thank you, Ben. I really appreciate that. And I know we're going to unpack your work today through really important storytelling. I'd love to invite our panelists to introduce themselves and discuss their positionality with this topic. Dr. Susana Alvear.
Good afternoon, everyone. My name is Susana Alvear. I'm a health physician and I work for a CFHI fully, and I've been there for over 20 years. We've had several students here in Ecuador. I am the medical director of the Global Health Program. I am also a college teacher of the Catholic University here in Ecuador, which is one of the biggest ones in Quito. And I like to do some research, especially related to women's health and community medicine. Thank you and welcome.
Thank you so much, Susana. Ben Blevins, I know you spoke to us earlier about your organization. Tell us a little more about yourself.
Well, I am my PhD is in sustainable education, and I am very passionate about how do we create transformative experiences, both for people of the global north as well as communities. And a lot of my work started in like the 1980s when Central America was a big deal, and we would host workshops on campuses, and the same 5 or 6 people would show up. And then we became in fostering academically relevant learning engagements. And we had business students, finance students, folks that would never think about any of these issues becoming engaged. And there's no greater learning than one's own eyes, hearts, and hands. And so for us, it's not as much about facilitating some kind of sacred knowledge from the global north, but rather it's engaging people in consciousness, critical education and awareness, as well as engaging folks that, like, once you know what's up, how do you become engaged in being part of transformation?
Thank you so much, Ben. Leslie Bravo, welcome, bienvenido. Please introduce yourself.
Thank you. Thank you so much. My name is Leslie. I'm a traditional motherhood and doula with, mother lactancy. I am a big support for the indigenous communities in the cover area of Quetzaltenango. I've got a degree in marketing, and we focus this and develop all of this in a holistic way so we can support diverse people, communities in need. And we've got this branch also of medicine plants. Now, this is a living spirit that transforms lives. So that's what I do. That's me, Leslie. Thank you.
Thank you so much, Leslie. Gonzalo Clare, welcome, and thank you for introducing yourself.
Thank you, Jess. I'll be presenting in English, but I'm speaking in Spanish here. My name is Gonzalo Clara. I'm a local coordinator for CFHI in the programs here in La Paz, Bolivia. I've been working with CFHI for over 22 years exactly. A couple of days ago, I celebrated my 22nd birthday with CFHI. During all this time, well, we've helped a lot in the development of the programs here in La Paz. My specialty is education and community management, and I work with the children or the kids in the programs here. I'm passionate for global health and colonization. I believe this is very, very important, and I find this to be an increasing topic in each population. And I think it's a great way. If someone asks me, what did you get of this? I would say we need to be decolonized. So I'm really passionate about this. I'm always reading. I'm always seeking for more knowledge and And this is what we try to transmit here in these programs. And not convincing them, but teaching them that they are part of a process, which is, and they're in this process of being better and getting decolonized. So this is something I'll be presenting later on. Thank you so much for having me here.
Welcome, Gonzalo. Thank you. Guadalupe Ramirez, welcome. Could you introduce yourself?
Buenas tardes a todos.
Hello, everyone.
Es un placer estar aquí con
It's a pleasure
ustedes.
for me to be here today.
Mi nombre es Guadalupe
My name
Ramírez
is
y soy la
Guadalupe Ramirez, and I'm
cofundadora de la
the co-founder
organización
of the
de
organization
Asociación de Mujeres del Altiplano.
of the Asociación de
Y
Mujeres del Altiplano, or Women's
estoy
Association of
trabajando aquí en
Altiplano,
esta
and I'm working
organización. Bueno,
here
soy
in
la
this.
fundadora,
Well,
la
I'm
fundamos en
obviously a founder.
1992 y
We've
fue a
been here
raíz
since
de
1982,
los
and
días oscuros de nuestra
it's
nación, la
since
guerra.
the dark days of
Estuvimos
our
ayudando a
nation, the war.
huérfanos y también a
We've been
viudas.
helping
Entonces,
widows,
desde
and
entonces,
ever
mi
since.
trayectoria
So
viene de
my
trabajar con
path comes
cooperativismo.
from
Mis
working
padres
with
fueron líderes
cooperatives.
comunitarios.
I work with
Crearon una de las
community
primeras
leaders,
cooperativas aquí en el
and
Altiplano
we
y entonces
created
he
one of
crecido,
the first cooperatives
crecí
here in
haciendo este
Altiplano.
trabajo
So I
y
grew up
para mí es
doing all of
un
this.
placer estar aquí con ustedes
So it's a pleasure
compartiendo
for
un
me to be
poquito
here,
sobre nuestras
sharing a little
experiencias
bit about
comunitarias.
our experiences and our community experiences.
Gracias.
Thank you so much. I'm Dr. Jessica Everett, and I am the Global Medical Director of Child Family Health International. I'm also a clinical professor at UCSF. I'm here because when I was a student, I fell victim to poorly designed short-term global health programs, and I injured patients, and I thought they were great because I didn't know enough about health and healthcare. And I had been socialized in a colonized way. So I'm here to, I guess, remedy that over a long arcing career. I've been a physician for 20 years. I continue to practice, and then I get to do global health education work in collaboration through CFHI. And I want to again thank Pamela for translating and interpreting for us today. I just wanted to kind of ask Ben and I to speak a little bit about the genesis of this webinar. We met in Massachusetts last fall and immediately kind of gravitated to shared stories and impressions. And when I look at why this discussion is important, part of the anchoring of it, I think, is even how we define or think about global health. So global health is a popular field of study. There is increasing number of majors, minors, and programs that go under the auspices of global health. It was formally defined in the Lancet in 2009, and you can see the formal definition there on the screen as a field of study, research, and practice that places a priority of achieving equity and health for all people. It also synthesizes public health and individual level clinical care and emphasizes transnational health issues and determinants. So that definition is used very frequently, but at the same meeting that that definition came out of, an alternative definition was put forth by a colleague from Kenya. And he said, quote, that global health is a concept fabricated by developed countries to explain what is regular practice in developing nations. And I think that definition needs some more attention, and it didn't get published, and it is important for us to hear not only those words, but the spirit and the concerns that are embedded in that description. In particular, the term fabricated is very powerful for me, and I think one thing we're going to do today is help put some more of the puzzle pieces together on how fabrication may be happening. There is a growing body of literature in decolonization of global health and international education, study abroad, volunteerism, and other disciplines. One of the aspects of colonialization is what's called the credibility deficit. And you can see on your screen a fairly long-winded and I think very academically advanced. I had to look some of these words up, and I had many years of education. So definition of what a credibility deficit is. I want to not only acknowledge the academic discourses in this area, and I hope that you will take a moment to read this definition. So I'm going to pause for a few seconds so we can all read it, and I'll read it out loud as well. So credibility deficit is when members of the dominant groups harbor prejudices and biases that lead them to discount the knowledge held by members of marginalized groups and their credibility as knowers. Deficits in academic global health arguably can be linked to underserved epistemic. Ben, help me with that word. Am I saying it right?
Epistemic, epistemology, and epistemicide.
Okay, epistemicide. Ooh. Okay, epistemic privileges afforded to dominant groups. That is credibility excess. Credibility excess can be rooted in historical patterns of social relations, including racism, sexism, and colonization, in which one social or epistemic group's credibility excess comes at the expense of a marginalized group's credibility deficit. So let's get real. What does a credibility deficit look like? What does it feel like? What does it sound like? You can see a very well-intended student in the middle there that may look familiar. This was about 20 years ago, and I went to Kenya on a volunteerism trip, thinking I was going to save lives in sub-Saharan Africa. I also, interestingly, went on a similar trip to Quetzaltenango, Guatemala. So this discussion is full circle for me. But what that looks like in practice is things like this, where I'm being put on the cover of a magazine and glorified. It looks like pictures to the right, which is called duffel bag medicine, where people pack up medications from a different place, bring them to a low middle income or perceived resource deprived setting and hand them out. And you can see undergraduate students in the top left there that are running a pharmacy. And that is in Latin America as well. And then you can see kind of the glorification of the volunteer, and the volunteer being both in imagery and in words framed as the solution to complex problems and to situations that are actually already being addressed more robustly. Some of our research in this area has also revealed that the limitations of visiting students is not only present, but actually the limitations of full-fledged professionals, faculty members, and practitioners. So this is a study of fully licensed practitioners from the US who have then transported themselves during short-term global health activities to low and middle income settings. They have practiced outside their scope of training and licensure, and they are admitting to the difficulties that they have. Some of the qualitative comments on the right-hand side of the screen, such as that they have difficulties around having sufficient knowledge of resources and disease prevalence, that they have difficulties navigating appropriate care and don't understand the cultural and socioeconomic context, that they don't understand the ethical context, that they don't understand the cultural context, and that they often underestimate the capacity and availability of healthcare workers in the low and middle income setting. When we think about what are some of the ethical missteps and practical missteps that happen, not only is there a faulty theory of change, like who's the solution, but also unsafe and unskilled clinical activities that harms patients. There's circumventing and undermining of local health systems. There's under or uncompensated utilization of local time, resources, and expertise, everything from gas that's put in cars, to beds, to food, to knowledge. And there's outsiders taking disproportionate credit for achievement. Look at any university's global health department's website, and you will see this in full effect. There is a lot of discourse on this, particularly in the global health realm, in terms of how global health, when executed inappropriately, inauthentically, and in a way that fabricates reality, actually upholds colonial structures and is actually harmful. So how do we get back to being authentic and not fabricating? Is having conversations like this. There are a lot of frameworks in global health over the last 20 years that have tried to push us in the right direction, right? So this is one out of Canada that I like. It's out of Graduate Medical Education in Canada, and it has learners in the middle, the roles we need to help them learn to play, ways in which we do that curricularly, but then it has the values and principles that are so essential, not only conceptually, but in an applied way. I want to especially highlight the values of sustainability, humility, honesty, and openness, and respect, those on the left-hand side. And I want to ask that you think about how these values are reflected in the conversations we're having today and how we bring them to life in our experiential learning, study abroad, and classroom settings. One data point I like is to actually think about what are the goals of exposing students to global health in an experiential way? What are the goals of exposing faculty to global health and practitioners? This is data from employers that says the number one goal should be understanding the context and realities of global health. And if you are fabricating reality or taking disproportionate credit or not understanding the reality where you're placing yourself, then we are not understanding it. We are not building the key competencies that we need not only to be good humans and good colleagues, but also be the professionals that employers want to hire. I think the other piece of this is being authentic about the impacts of what short-term global health experience have on communities that receive students. This is a study we did. It's actually kind of an amalgamation of two studies, one of CFHI programs and one of over 35 countries that receive students. And the impacts of students, no matter what they do in a clinical or technical way, is improved English proficiency for those who come in contact with them, increased prestige of host institutions that host them, which again, there's a lot to unpack there. Fulfilling local practitioner sense of global citizenship. So all the local community members who get to impact students from other places and make them better off and more understanding of global realities actually are fulfilled and feel more self-efficacious and actualized. Increasing ability of local individuals and organizations to build and leverage networks, and movement of and access to resources. And I will take you back to the fair trade learning that Mike brought up earlier, because it's key in terms of how we do that. Ben, what are your thoughts on what this opportunity and challenge are?
First, I'm super excited, and I was motivated to do this because attending the conference and hearing Jessica speak, I was like, how can I rope her into presenting to everybody we work with? Because she is significantly more eloquent and laid out and credible in her presentation than I could ever hope to achieve. So this is part of our Machiavellian maneuver to have this on tape so we can play it for everybody we work with. Because I say, oh man, I think it's a fabulous introduction to this work. And I'm very excited and appreciative for you guys joining us today. I'm excited that we have this space for an honest, open dialogue about the complexities and responsibilities involved in global North medical school partnerships in the global South. These collaborations hold immense potential. They can unlock resources, foster mutual learning, and help build capacity in very meaningful ways. But they do also require us to take a hard look at how we approach them and to ask the question, are we unintentionally perpetuating harm or reinforcing inequities? And how can we shape our work to embody fairness, justice, and reciprocal growth? This discussion isn't about assigning blame or pretending any of us have all of the answers. Instead, it is about learning together, and I'm super excited for the opportunity to learn from such great practitioners, sharing insights that have helped us along the way, and being transparent about our ongoing challenges. One area that has profoundly shaped my thinking is the importance of integrating deeper, more holistic approaches into this work, particularly because we are working with Indigenous communities. Partnerships like these can't just focus on delivering resources or solving individual problems. They require broader, systemic level changes that recognize cultural, social, and ecological interconnectedness. This brings me to a concept that I find incredibly relevant, and it's a paradigm that I've been going to in some of our participatory action research engagements. We have been swimming in the waters of unitary transformative paradigm, something developed by a theorist, Margaret Newman. It was kind of crazy when we were reading it. It's things that the elders that we work with, their perspectives. So it challenges us to view health not as an isolated or linear, but as an evolving, interconnected process. This paradigm shows the importance of an approach that we work together as collaborators, not saviors, and to see communities not as recipients of aid, but as vital partners with invaluable knowledge and wisdom. By focusing on interconnectedness, transformational growth, and relational balance, we can shift how we engage in ways that are not only more ethical, but also truly effective. And I'll leave it off because I want to leave plenty of time for the people with significantly more wisdom, knowledge, and experience than I have to share. But
Wonderful. Thank you, Ben. Let's invite some of those people who have more knowledge, experience, and perspective than you and I. So I would love to invite the Highland Support Project team, including Leslie, Ben, and Guadalupe, to speak to your experience with some of the well-intended but harmful visiting global health short-term experience teams and individuals you've seen.
So I'm sorry, but I'm going to jump in again to introduce our segment and to introduce AMA, the Association of Highland Women. And it was formed by Guadalupe and some other community health workers over 20 years ago. And this was solving a problem. And the problem was that in Guatemala, for indigenous young women, there were very limited opportunities to develop professional experience, professional learning. And it was rather dramatic, the level of sexual harassment and violence that community health workers faced working for Ministry of Health agencies, NGOs, nonprofits. And so the organization AMA was formed to provide a space to develop indigenous women leadership in the health sector and to provide them with the opportunity for leadership to be voicing the needs from the grassroots, from a indigenous women's perspective of what their priorities were, what their needs were, and the experiences they were facing. So Guadalupe will start off with sharing anecdotes from her lived experience, one in her community of Tecutla, San Marcos, about how duffel bag medicine brigades can displace local actors from the health sector. And then she will talk about the NGOs associated with the Methodist Church that have come down, and because of the unique kind of political structure of evangelical churches, how unqualified individuals, the local pastors, are elevated to positions of power within the community while completely displacing authentic community health workers. And Leslie, who is a traditional midwife extraordinaire, will share about the ontological displacement of biomedical actors coming in and centering Northern biomedical thinking and reductionist thought. So, con mucho orgullo, yo estoy introduciendo a Guadalupe Ramírez.
Good evening, everyone, again, from here in the Mayan earth of Guatemala. Firstly, well, my name is Guadalupe Ramirez. I'm an indigenous woman, Maya mom, from Tejutla, San Marcos. Geographically, just to place a little bit of context, we're a small town in the border of Mexico and Guatemala. First of all, I would also like to place a little bit of context of what the Maya vision is and our cosmovision. Today, this is a day that we call Achtu. Achtu is a day within the Mayan calendar, is a sacred day of the sun. So we always say, on Achtu, what we ask for is from our mouths, from our words, we ask for sweetness and kindness as flowers. And we also say, in this aspect of health workers, we can also say that our feet and hands are the tools or are your work tools so you can help other people. And from this perspective, I can tell you that, well, the Spanish people invaded these regions, this earth, and from then, our ecosystem changed a lot. The written knowledge, which was written by our ancestors, everything was burned. And knowledge has been rescued from generation to generation verbally. However, we've adapted to certain circumstances that we live in today. There's a lot of missionaries who have come to our towns in different times, from different places, different nationalities, and in different ways. I can speak about the mission here from Belgica, and they arrived in 1950s. They supported not only with wording, but they also helped with resources or courses, cooperative courses, so we could have access to the market and we could begin to trade with our products. Now, their mission was also to install a medical clinic. And I remember in that medical clinic, we always had to pay with time, now with health and with economic income from our parents. 5 members of our community began to be doctors, and they were able to go back to the clinics and begin working in the clinics that the Belgium mission left. So with these doctors who came back, they were also able to train, and this is when one of my aunts was trained in pharmaceutics. So she helped in the local pharmacy, and at the same time, she was able to coordinate with one of the local doctors so the pharmacy could be equipped with the necessary medicine, because the doctor was telling her what the diseases or the most common diseases were that needed to be treated. So these not only gave my aunt and all the families around a way to have income to support their families, but the issue there began when the northern the northern missions began arriving, because they could not longer compete with the services that were free. So the result was quite devastating. It was devastating for the local sustainable health infrastructure that we had in the community, and it created some sort of dependency, and that is hard to reverse. And unless a Canadian have plans to come here every 3 months for a century, the harm and the damage to our community has been, I mean, we haven't had a lot of benefit. I've seen a process, and this is similar in different communities, which have also been affected by the dark years of war, where local efforts, such as a health center, a child health center, or a women health program, they were undermined as well. And this was because of the fluency of certain churches that went to the nation and to the region. I'm referring to the Quiche region here in Guatemala. And they arrived to the region, and the local, evangelic pastors, they took advantage of all these medicine and local doctor system, and they were using that to attract more people to their own church. So the other experience that we see and that we've had is we've found in certain communities, we've seen doctors who arrive abruptly without the necessary coordination with the communities. And sometimes I've been able to see, because women have come to me and have asked me, hey, which one is the best product to use? Is it the product that the mission from that arrived that day is providing, or the doctor that I've been visiting because of the health problem that she's been having? And with a lot of embarrassment, they come to me. And I say, hey, I have no medical experience. And I don't know about, your circumstance or why you've had to go to those doctors. But I consider that you need to do whatever you find necessary and take the medication. So what I think is that the local doctor is providing something that you could go back to in case that medication has some extra issues over your health or some effects. So sometimes people here wait, and they prefer to suffer for 3 months until they can go to a free clinic because they know they cannot pay for it. They know they're going to be receiving free medication, and they prefer to stay with that pain instead of changing it. So we've got our organization is trying to educate the community so they can have higher responsibility and understanding, responsibly understanding that personal health is important. So they can explain to the doctors how they feel. And so the opportunities that they have can be well understood, that they can have a choice, that they can have different treatment systems so they can feel better. So I'm really excited and happy of being able to share a lot more stories, but I'm also, leaving the floor for Leslie Bravo, and she can share a little bit more about the experiences related to the traditional midwives formation, and the impact that this has in our culture and sustainability. Thank you. Thank you so much. We, here in our culture, always before going to someone else, we always ask for permission. With a lot of humility, I'm here with you, and I'm be asking for your permission to be able to tell you a little bit about the beautiful process that I do by being a midwife. So the gift of being a midwife, I have this from birth. I'm a traditional midwife. I am a midwife that, with my ancestors, my grandparents, they gave me the beautiful gifts of being there for other women. Us, as an organization, as health workers, we are here supporting a lot of women who need to have someone there with them, but to be able to get to this process and being able to be there for another woman, I was obliged to try to find an organization which would give me a degree as midwife. Because I had the gifts, I had the knowledge from my ancestors, but I had no document or legal capacity that would help me do that. I had the opportunity of being certified as a professional midwife in the area of Quetzaltenango, where I had the opportunity of being able to attend the practices in general hospitals. There, you're astounded. You're with your heart. You're left with your heart broken because of the malpractices that you can see. There, we can observe that a woman just turns into an object. A woman is mechanized for birth by the practitioners, the doctors. They use a lot of violence, and with this violence, we've also have the postpartum effects. So this using women as a mechanism leaves out this spiritual attachment, the feeling, that unique feeling of being able to be there as women, that we're giving birth, we're bringing life, and we're just used as something mechanic. Like, we lose the spirit. We no longer have that spirit, that center, that closeness that we have as women. So by the association and with this Asociación de Mujeres del Altiplano and Highlands Project, we have now a program to be there for other women. Now, being there for women is that they're mentally, physically, and spiritually, so they can have that joy, that hope, and we can give that to another woman. In my case, in my personal case, I had sequels of the internal war that I lived, and they were really big traumas because my father was kidnapped and murdered internally, and with that, I lived physical violence, sexual violence, violence which marked me, and with that, I found commitment to closeness, to be able to be there for other women. And we get close because we support a lot of indigenous women who have no voice, who have no right, who are left silenced. Women who cannot go to a place and say, "Hey, I'm hurting about this. I need these." And with the program that we have, we can get close to them. We can earn their trust, and we have this approachment, shoulder to shoulder. I can listen to you. But to be able to get to that process, we've got a long way to go, a long path, because we get close to them. We're no longer health workers. We are now as ishotanel. Now, this is a word in the Kish language, which is called the woman who is there for another woman. So this is so incredible, so holistic, so magical, being able to be there for another woman. So this is very, very important. And I really felt the words that you all said. We are no longer here as a group of people. We are here as a group who are there to collaborate. We can all be partners. We can all be committed to be able to support someone else. So thank you for your time. Thank you for this opportunity. And as I asked you for your permission to be able to speak, I ask for your permission to thank you all for this beautiful moment. So thank you.
Thank you so much, Leslie. And thank you so much, Guadalupe and Ben. I want to invite Dr. Susana Alvear to share her perspective from Ecuador.
Hello, everyone. So what can I present? I was presenting some slides there in English, but I'm going to be speaking in Spanish. And just to demonstrate a little bit of how we can work, better with the students, with people who want to learn a little bit more about global health. Just to be able to share a little bit, Ecuador is one of the smallest countries in Latin America. We are near the Pacific, and we're famous because of the Galapagos Islands. Some of the demographic indicators is that we are a population of around 18 million. Our life expectancy is about 75 years, more or less. We've got age distribution of population, which is from 15 to 64 years, 78%. And we've got an expenditure in government health. And this is very important, I find, because this can be a breaking point for missionary support, foreigner support, for economic income. So it says we spend 13.9, but this is not real. Currently, we are less than 5%, but this was published. Some other problems that we see, and that's why we sometimes see a lot of international medical help here, but a lot of countries do not have these. For example, here in Ecuador, we've got enough doctors. The only problem is doctors are focused in the big cities and not towards the rural areas. So this is a very important fact that we need to have present. And I present some certain causes of death, like non-communicable diseases like diabetes, hypertension, heart disease, and it's 62%. The rest is communicable infection, maternal, perinatal, and nutritional conditions. And certain other injuries are 9%. So this information is really important for me because when we are planning a curriculum for students, for foreign students, we need to understand that what are the local indicators? Why? Because, I've worked with families, with students a lot of years, both in the rural area as in the family area. I do a lot of women health, and I've also supported investigation processes to eradicate infections in Ecuador. And it's very interesting to see because we've got a lot of foreign people coming here, and they try to see that we only got infectious diseases in Ecuador, and this is not real. So here we see hidden curriculum, both from people who are experts in something, and they probably think that that's the only thing we need. So we need to consider all of these as issues where we can act on. Now, speaking about the structure of the national health system, just so we've got a little bit of idea here as well, this is important because all our experiences and support must land in locally. So our public healthcare system, we've got, I think that's in most of the countries in Latin America, it covers 70% of the population. Now, this means free attention. In Ecuador, it's a constitutional right to have access to health and free education. And this is not only for Ecuadorian people, but for every single person who lives in Ecuador. For example, here we've got we've got a lot of Venezuelan people, and we need to provide freely health and education. So we also have the Social Security healthcare system, which is a private system, but it's controlled by the government. And we've also got the private health sector. Like I said, the public system covers 70%. But what are the aspects of the system, and why is this important? Because if we need to have a curriculum, we also need to understand how a health system supports their people. Our health system is based on a universal healthcare coverage, and this is something that the Constitution mentions. I really believe this is less than 60%, but this is what we try to cover. We've got a focus towards primary health care. That's why I am a doctor for family health care, closer to the community. And we've also got disparities, geographic disparities. We've got communities, indigenous communities, which live 3,000 meters away, and we need to get there with medical attention. And this is a huge issue because we've also got the farthest side, and we need to get there. And this is really, really difficult. But that's part of being Ecuadorian. So what are the opportunities and the challenges that we can see here? Well, we can see that we've got limited resources. Both in discussions, how we can help. So we've also got the medical professionals in all the medical area, because we don't really have a lot of nurses. We don't have dentists, especially in the rural areas. So we've also got inequalities in access, both socially marked by the education level as in the economic side. And we've also got the external factors. So, for example, we see a lot that we see a lot of the petroleum exportation. If that value lowers, the economic resources for the country are lower. So we really have to fight this with health principles and constitutional principles of thinking about health as a free thing for everyone living in Ecuador. And this is very complex. So, from our experience, I'm a doctor who has gone through a lot. Um, a little bit about me. I went to one of the missionary hospitals and I got my education there as a family doctor. And this is one of the best hospitals in Quito, is the Mosandes Hospital. It was founded by a group of evangelic people. And this was very interesting for me. Why did I study there? According to my perspective by then, it was the best hospital which created family doctors. But this was very interesting because despite it being a hospital created by missionaries, they built something that's very important. They created this part of getting knowledge to Ecuadorian doctors. They were never over them. And I think this was the first thing I learned, to get into everything that means global health or international health. But as Leslie and Guadalupe mentioned, these missions, this international help, if they're not well planned, they can be very harmful towards the communities. Like they mentioned, they create dependency. As it was mentioned before, if you go to a missionary group and they were just here for a week and they provide everything, good or bad, people are always going to be expecting that. And health resources are limited. So we are creating a parallel health system. This means we do not trust the local health system. And that's not what we should be doing, because when the missionaries leave, or a doctor that was 20 years in Ecuador and they leave Ecuador, so what is left for that population? We do not need to create dependency or parallel systems. So this drainage of knowledge of local doctors, that comparing to here, especially in Ecuador, in Quito, we think, and it's true, that we've got a lot of development in Northern medicine, in the US medicine, Canada, but we cannot transmit these to our people, saying that foreign doctors are better than national doctors. Because again, we are creating mistrust, and the local healthcare providers might feel that they are not adequate, and they probably won't be able to continue trying to improve maybe the quality of medicine and our people. As we had spoken about before, we can have certain priorities that are probably not directed towards the local part. Like I said, a lot of people believe that we only have infectious diseases, but we probably have a lot more diabetes issues in Ecuador. So practices and inappropriate or unsustainable practices. I saw many times that third grade, fourth grade students from the US came here to do direct support in surgical practices, and this is not allowed. Ignoring local protocols. This is very important because resources in our country are limited, and probably we're not going to have the best antibiotic to treat meningitis, but we're going to have an antibiotic that, according to the local studies, works in our country. So this is very important as well to consider. And something else is donations of inappropriate, or worse, even expired medications. This is completely unethical, and we need to be very aware of that. Some other issues that we've had are ethical concerns and the lack of cultural sensitivity towards the cultural part, the local part. Big issues, for example, the lack of continuity, like we mentioned, being a hypertense patient. I give them medication for a month or two, and that patient, what are they going to be doing next? They have mistrust of going back to their community, to their local community, and maybe they're not going to be taking that medication because how are they going to be comparing it? What they gave me before is better than this. So we've got that ethical problem. So we also disregard the cultural norms of each community, like we explained before. And sometimes we don't even ask for informed consent. And this is very, very serious, especially for small procedures. We believe that we can do everything and that we do it right. And obviously, big term, it was, medical tourism. Medical tourism for volunteers. Actually, this gives me a lot of excitement because when I speak with young people or young evangelic churches groups, they come here being very motivated, but they've got a unilateral vision. They don't have a cultural or social vision of what they need to do. And that's something we need to change. We need to inform them. So this motivation of being volunteers grows and improves because I do believe that this needs to be a bilateral accompaniment and trust, and we can grow from that. And also, we've got the economic and resource distortion. Why? Because sometimes, like we mentioned before, we can probably see something that is being done in the community that's not being needed, and that's not a priority for them. For example, here in a community, like 10 years ago, we went there and asked them what the most important part for them. I was a doctor. We had a group of doctors, and the local community said, cell phones. And we were like, how are we going to respond as doctors to the community needs that were cell phones? So just to give an idea of everything that happens when we try to improve things. The other part is we do not know what happens with the data collection and the patient's collection information. And this is something that we also need to pay attention to. This needs to be transparent and ethical. And obviously, the lack of coordination. So what do we do? Well, with CFHI, we've been working a lot with landing the best behavior of our students to work for what we call global health. So this has always been a constant change and study, and I thank Jessica here and all the organization for this permanent motivation of always trying to improve and do the best for the local communities. Without the organization, without this, I wouldn't even be working. So I believe this is very important. Lately, we've been trying to find new ways. We've been studying a lot, and something very difficult that to me, at the beginning, it didn't mean a lot, but fair trade, now it means a lot. So this was, to me, when I began reading about this, I was like, but what does this have to do with health? It just works for economy or business. But this is what it means. And it means fair trade means getting primarily associated with goods and economic practices to its core principles of ethical sourcing, fair compensation, and community well-being. And this is what we need to transmit to everyone who wants to support, because we do need it, but we need to do it right. So what are we moving towards? What does fair trade do? Well, we need to have a bilateral and adequate collaboration. We need to have responsibility. We need to transfer knowledge, but it's a bilateral thing. Like we mentioned before, traditional medicine, we need to respect that. But if I know maybe about a Papa Nicolau test and I know how to do it better, then I can also share that knowledge. Not only from one side and saying what I do is better than what you do. No, that's not right. And this is very important for us in the country as well, because currently, within the health system, we recognize now traditional medicine. But this has been a year-long struggle because it needs to be at the same level of normal medicine. So speaking also about this compensation, so what the people win, those who come here to support internationally, what do they earn being here in Ecuador? And what do local doctors here in Ecuador earn? And this is something that Jessica has asked me. What do you do? What do you earn? What do you win? And to me, this is very clear. The first thing is understanding that we are equal. And here we're speaking about this ethical and social justice treatment. We are the same. You teach me, I teach you. You give me, I give you. And to me, it's fascinating to work with the students because, for example, I started telling me, how do they do it in the US? How do we do it? And we've spoken a lot about this, techniques and everything, but in the end, the result is the same. The result is saving a life, improving a quality of life. So this is the important message that we try to transmit to the students that we receive. Always having this ethical behavior, which is the basis of what helps us develop everything that means global health. I also believe it is very important to know about the local needs, empowering communities to find their own solutions. Because oftentimes we have the experience and expertise and we would like to say, this is the best. But like I mentioned, for example, the cell phones, I thought they would be saying we need water. No, they never mentioned anything about that. They said we need cell phones. So I think that transparency, ethics, and being able to realize what we're doing, I think this is important and impressive, and we need to do it to be able to strengthen global health. Here, we've got some aspects that we can do to mitigate all these harms that we might produce. And I would just like to again mention here in Ecuador, we've got regulations. And we've got regulations for international medical assistance. This is a process that we need to do, a lot of paperwork, but we do have regulations and we need to abide by them. Now, once again, thank you so much. It's very exciting to speak about all of these. And yeah, we're here for you. Thank you so much.
Thank you so much, Susana. I'm going to ask you to tell one other story. Once you shared a story about a Ziploc plastic bag of medications. I don't know if you remember that story, but could you share it?
Yes, this was in a rural progression. We went to the coast in a population that we've got Afro-Ecuadorians and indigenous population, and when I was working in that community, a patient, it was around 20 medications that she had, and she had vitamins. She had around 2 to 3 types of vitamins, antibiotics, like 2 or 3 types. And she came to me and said, hey, can I take all of this? They just gifted it to me. And to me, what did that mean? To me, that moment was like, wow, how much money is being wasted? This patient that doesn't even need it. And the most important message for that patient back then was, with the vitamins, you can improve the family's nutrition and health. And the antibiotics can be taken. And I was like, if I'm not sick, what do I need the antibiotics for? And this happens a lot when we do not have adequate orientation of what global health is. So, and there are thousands of stories like that.
Thank you. I'm so glad that patients have you and health leaders like Leslie to help guide them when short-term global health visitors are handing out medications and plastic bags and a slew of other things. I want to invite Gonzalo Clare to discuss the realities in Bolivia and some solutions that he is on the forefront of. Welcome, Gonzalo.
Thank you, Jess. Good afternoon, everyone. Thank you very much for having me here. I am more convinced now that we live in a bubble in Bolivia because none of the things that you mentioned happen here. None of them. We do not have medical missions here at all. We do not take them in. Whatever health that is created and made in the country is run by the Ministry of Health. They are the only ones that are authorized, and that's per constitution. For Bolivia and Ecuador, I think the constitutional rights are very, very important. We mentioned the constitution permanently. In Bolivia, constitutionally, we cannot accept anyone coming from any other country to come here and provide help for our population. This has been a long process. Back in 2008, USAID was kicked out of the country. Bolivia was one of the few countries in the world at the moment that decided not to accept USAID help anymore, help, assistance, whatever you want to call it, because of a number of reasons. One of the most important, I think, is the agenda that USAID had. They had an agenda and they wanted to enforce that agenda in the country. And actually, it's been running until not very long ago with support to journalism and everything. And then, people realized and said, hey, the checks are still coming to the country, right? Support for journalism, free journalism or whatever. Actually, Mr. Musk just kind of busted, the scheme in the United States and said, hey, there's a lot of money being funneled to this, not only in Bolivia, in a lot of different countries. But the point is that back in 2008, when USAID left, we already had, we were on the way to determine our own sovereign health system. In 2019, it was enacted. We have free medical care today in the country. So whatever medical needs you have, you go to hospital and that's it. You have the attention you need. It is very expensive, very, very expensive. Right now, Bolivia is investing around, and I have the number here, we are investing around 16.5% of the national budget on health. It's still not sufficient. You go to hospital, the hospital is crowded. A lot of people want medical attention. A lot of people know that the medical attention is free and they go for that. That is very, very important. And again, it's really expensive. Now, what happens when you depend, and I'm going to talk a little bit about colonialism here. But what happens when you depend on someone? There is something that pays for this health system. One of them is the oil revenues that we are losing, like little by little. We're just losing ground on that side. I think that Ecuador is very sensitive to that as well, as much as we are. We're spending a lot of money right now on systems that are free. So what happens? What happens is that when you need to pay for free education, free health, free this, free that, which we have a lot of here in Bolivia, we have a lot of medical, and not only medical, we call direct cash transfers, which has enabled us to have more than 98% of all deliveries in the country done in hospitals. Right, that is a great number. Our mortality rates, our rates are still high in comparison to the rest of the region, but they have dropped dramatically. So that means that yes, our numbers are high because they were very high before, because of our dependence on foreign assistance. How does that work? Look, you have to pay for the system, and the system comes. And it's paid by revenues, by this and that, in taxes. When you depend on medical help, you depend on budget, you depend on a lot of things from foreign assistance, then that mechanism is broken, you see? So you are not able, as a country, to collect all the taxes you need in order to pay for all the things you need to pay. Now, we are solving that. Right now, Bolivia has one of the highest tax revenue systems. I mean, in terms of how much they tax us, and in the region, we are above the international standards by more or less 1%, which is a lot of money. That's how we're paying. But that has been enabled because we were able to build that system and to build a base that is going to pay for what we are today enjoying. Again, don't get me wrong. Don't think that, this is paradise or anything. It is not. We have problems. We have problems with the health system. There are out-of-pocket expenses that we need to pay, but we are dealing with the problems alone. As a sovereign state, we are doing this with a lot of dignity. We are not asking for help from anyone. We are doing this ourselves. That gives you a lot of freedom. That gives you a lot of say in what you need. You don't need the medical missions that go and, offer free medical assistance for 2 weeks and then leave. We don't do that. We don't accept those missions. I haven't seen missions here in Bolivia for a long time because, I go to the airport a lot, right, to pick up the students that are coming to our programs. I haven't seen doctors coming to Bolivia to give that kind of assistance because they are not accepted. We do have some level of international assistance, but it's in a different kind of level, right? They give us assistance, yes, and it's, translated into projects, into roads, into sanitation, a number of other things, but not in health, not in education. We don't do those things. We are alone. Now, how is that reflected on our programs? And that's what I would like to go into now. We tell students, and we follow a lot of the guidelines that we have developed at CFHI, and allow me to share my screen, and I'm going to address that a little bit. But before I go into this, I really think that the fact that we don't have any assistance anymore is just wonderful. Look, I used to work, and this was during my years with CFHI as well. I worked with a lot of cooperation offices here. I worked with the United Nations Development Program. I worked with the Dutch Cooperation Agency. I worked with the French. I worked with a lot of different organizations. Not on development programs, we were offering other kinds of support systems, but they left. They all left, right? Because Bolivia said, look, we are a sovereign state. The one that dictates what we need and what we do is the Ministry of Health. If you want to work in Bolivia offering any kind of assistance, doing anything you want, no problem. You go to the Ministry of Health and then you get your permission from them. NGOs are regulated. When this happened, NGOs went crazy because, NGOs were doing whatever they wanted. Then the state said, wait a minute, you are going to tell us exactly what you're doing, how much money you are spending in the country, what you are spending on, and then we're going to see if it's okay or not. So then NGOs have been highly regulated, taxed, and of course, there's a lot, very strict follow-up on their, I'm not going to say activities because it sounds like, there's an underground thing. No, it's just that they have to act according to the policies that the Ministry of Health has enacted. Some programs from the Ministry of Health, zero malnutrition, HIV program. People here who are HIV positive get all the retrovirals for free of charge. They just have to show up to the doctor's office once a month for the checkups, and then they get all the retrovirals they need from the state, from the health system. Chagas, the Chagas system. Then we have intercultural medicine. That's another thing. That has been part of the country since 1987, more or less. What happened? We decided to integrate indigenous medicine into our health system, and they work parallel. So we have basically 3 systems in Bolivia. One is a public one that covers everyone. You can enroll in the program on your own if you want. You also have the private system, and you have indigenous medicine. How does it work? You need a license. How do you get your license? You go to the Ministry of Health and you say, I am a matrona, or I am a traditional practitioner. I guess they test and they do whatever they need to do, and then they give you a license, and you are a licensed practitioner, right? That's the way it works. Those are some of the programs. Then you have something that is really, really important in SAFSI. SAFSI and community medicine. SAFSI is a multicultural type of medicine. And it's basically, we're talking about teams composed of PAs and nurses and assistants that go to communities or work in communities in small teams, right? In small communities, you have the possibility of having traditional medicine if you want, or you can have what we call, Western medicine style, right? So you can choose which one you want because that goes with you, that respects your beliefs, that respects your way of life. So that's the way you do it. That's especially clear in rural areas where, a lot of people don't speak Spanish, for example. They speak other languages. That's why we call ourselves plurinational state, because we are a plurinational state. There are a lot of different nations living within the boundaries of this state. So that's where the name comes from. right? Respecting, honoring languages, ways of life, geographical regions, right? Which is really important when it comes to defining an indigenous population, right? So that's the way things are done here in Bolivia. And I say that we live in a bubble because I think we have taken the step that a lot of others need to take. I'm not trying to tell you, hey, this is what you need to do, because I am not at all. It's not my reality. I know more about what is going on here than what's going on in Ecuador, Guatemala, or whatever else. I have no idea. But what I can tell you from this point of view is that we are doing well. The system is in problems because you need a lot of resources, right? But we're doing okay because we're sovereign, because we are saying what we need and what we don't need. And we are saying, you are going to do this and you are going to do that. But you're addressing Bolivians. You're not talking to cooperation from the Netherlands. You're not talking to the cooperation from France or from England or from Germany or from the United States. You're not talking to them anymore, right? And we are in this process of decolonization, which is something I think it is really important. Within that reality, we approach our programs in that sense because our students come to see what the system looks like and they come to experience what this program is all about. But again, from a very observational point of view, we do not allow students to participate in any kind of hands-on experience at all for a number of reasons. One of them is that patients' rights in Bolivia are really important. So patients are empowered to the extent that they say, wait a minute, what is this person doing and why is he or she treating me? Who's that person? Where is he or she coming from? We respect them, but I want someone, that speaks my language, someone that knows me, someone that, is a Bolivian to treat me, right? Now, within that, this is the way we engage in our international global health programming here at CFHI. So our main idea is to benefit our trainees. I mean, based on the idea that there is a lot of demand, we want to benefit the students from the experience they are going to have here in Bolivia, right? But at the same time, and I want to bring here something that Dr. Susana mentioned, and that's the fair trade learning principles. We follow the fair trade learning principles to the T. Why? Because we think that we have to minimize to the utmost extent the impact on the community. And I'm saying impact, not benefit, right? Because they're different. Benefit is something that is good for you and is good for the community. We want that and we cherish that. And we tell the students, look, we have created this network where we are going to insert you. And this has taken us a long time. We respect our local practitioners. Why? Because they know the context, because they know what people need, because they know how to do things. You are probably going to do this in the United States or wherever you come from differently. Absolutely. Probably, yes. Maybe you have more means, probably. But these people here know what they're doing and they are responding and they are saving lives. And that's what is important. That's what we want you to see. That's what we want you to experience here. We want you to see that there are other ways to do things. And at the same time, you're cooperating with this community. You're part of the community because you're respectful. Now, how do we do that? Well, we address the language and cultural barriers. We have a number of different resources to do that, right? And that's something that CFHI does very well. We do a lot of pre-departure training. CFHI does part of it. I do part of it, right? Because with my students, the students that are coming to Bolivia, I have pre-departure meetings and I tell them, look, you're coming to a country that is completely different from where you're coming from. It's totally different. Enjoy the experience, enjoy the ride. It's going to be beautiful. It is going to enrich you because you're going to see the same things you do done differently, right? And at the same time, you're going to be part of that community. And we want you to understand that cultures are different. Cultures defined as sets of behaviors, right? So what is good in your community probably is not good here. So learn to see what is good here, take it back home. And when you have people coming from that context, you will know how to handle that because you will be able to speak in their own language. You will be able to respect that culture. And that is common in the United States right now. To mention just one country, right? The United States, right? And we know that it's a melting pot, right? There are so many different cultures. This is the most culturally diverse country in the world. There's 120 different cultures present in the United States today, 350 million people, 120 different cultures. That's incredibly enriching. As a practitioner, you're going to see a lot of that, right? You're going to see a lot of patients coming from different contexts. So if you can talk, you can address, you can discuss things with them in their own terms, not in yours, in their own terms, then you're going to be an efficient and a very effective practitioner. Are we going to help you do that? Hopefully we will. That's our idea. That's our main point. How do we do that? Again, inserting you in a context that is different and helping you, not really helping, giving you the tools for you to see that local perspectives, program designs, cultural beliefs are different, enriching, and they are going to make you a better professional, right? Therefore, again, bringing what I said before, during clinical rotations, the students only see, only observe. They are never involved directly with the care. And again, that has to do with per trade learning. We are respecting the community. We are there saying, hey, how do you do this? How do you do that? Just recently, I was discussing with patients, and something that is interesting. Let me let me tell you that story. We had a program, and we've been running the program for the past 3 years. It's a physical therapy program. And then one of the rotations, it's a short-term program, one of the rotations was Hospital de la Mujer, the women's hospital. And they went to the women's hospital and they saw that PTs were doing something that in the States is not common, and that's physical therapy with women who are pregnant, right? And they said, hey, this is really interesting, and I think that this is something we can take back home with us because this is helpful. It helps women, right? So you see, that I think, amongst other things, is one of the results of this exchange. You come, you learn, you see, and you exchange information with others. Right? What Doctora Susana was saying, hey, how do you do an hysterectomy in the States? This is how we do it in Ecuador. This is how we do it in Bolivia. These are the means we have. How do you do that? And then we exchange information, right? Now, all our work is also ethical, and that is something that was mentioned before. We have a clear ethical guideline, which is that ensures the quality and the respect of our international programs and throughout all our programs in Bolivia. And each one of the actors, each one of the stakeholders has a clear role, right? They are outlined in this slide. Now, how do we insert? How do we work? How do we design our programs? Being respectful, being culturally pertinent, being culturally respectful, inserting ourselves in the community, learning the language. In the case of Spanish-speaking countries, which is really important, learning the language. They do the same in India. They take Hindi lessons, right? So they take lessons, they learn, even if it's a little bit, then they do that. Then we do a lot of reflection as well. During the program, post-program, before the program, we do a lot of discussion. We tell them, how do we do that? We have all these tools here, right? And that's what CFHI does. I think, and I'm not really thinking, I'm convinced that, well, CFHI stands for decolonization, right? And it's a hard process. It is hard to understand. It is hard to grasp. And it's even harder to implement. But it's been a long time, and I think we are getting there. We are developing, we are running programs that are decolonized, that cooperate with the communities, the local communities. They insert themselves in the communities. And you mentioned, Jessica, the gains for the community, improved language. That in itself is is a benefit, saying, hey, I have to understand more. I have to communicate better. I have to learn more from my visitors. I'm going to learn English, and so on. So these are the tools we have. That's the way we do our work. And that's what we're proud of. And I think we are making a difference in the communities we visit, and we're making a difference in the students that we receive in our programs. And we're proud of that. And we enjoy our work very much. And, you know, I have Doctora Susana here with me, and I'm sure she's going to agree with me. You know, this has been amazing, you know, seeing the students, learning from them, listening to them, just looking at their faces, you know, how wonderful everything is for them. To me, is just incredible. So thank you very much for having me, and thank you very much for supporting me and for my passion, you know, about CFHI. I really appreciate it. Thank you very much.
Thank you so much, Gonzalo. We're having some of the Q&A and discussion in the chat, so anyone who isn't following that, take a look. I think in light of time, I would love to ask for closing comments from each of our panelists, and really encourage you all to stay engaged in this discussion and share your practices through these wonderful organizations you see on the screen. Let's start with Leslie. Leslie, what are your closing thoughts, reflections, or advice as we wrap up today?
Thank you. We've got a lot to learn. I believe this learning process, is going to be really enrichful to allow us to continue working with the constant challenges that we've got in health and the challenges that we've got in the communities. Being able to share these experiences, learning from Gonzalo and Doctora Susana and all the panelists, this is amazing. Let's be partners. We need to be partners and center ourselves and focus ourselves in health. Thank you.
Thank you so much. Dr. Susana Alvear, what is some of your closing thoughts and comments?
I'm really excited, really happy to share with partners here in Latin America, but all these auditorium. And I'm really motivated because there's a lot of people who believe that supporting us with respect and ethics, we can improve the global health system. So thank you so much.
Ben Levins, tell us your closing thoughts.
I'm just so excited and jazzed to hear from so many wise people. And want to say that we have such a sacred responsibility, because we are working with the future and those that will create the realities and to move on. And a lot of times it's funny, we call it fair trade, or questioning why do we use fair trade with health or education? But in the world we live in, health and education is a business. And I think in our work, we are frequently pulled away from focusing in and be engaged with the sacredness of our work. And I really appreciate Leslie and Lupe for contributing this notion that it actually is a very sacred path we're on, and that we're engaged with creating tomorrow.
Thank you so much. Guadalupe Ramirez, take us home with your closing thoughts.
Thank you so much. To me, the most important part is respect, ethics, and not being looked at like objects or like experiments. Here in Guatemala has served as a lot of pharmaceutical experiments. Maybe that's why we've got a lot of sheeps, and they come here to the ports in Guatemala. And Isabel, San Jose, we've got a lot of sheeps from the US, and they are here. So what information did they take from us? What did they do with that information? Here in Guatemala, I'm not sure about the exact date, but Benjamin probably knows what happened. But they made some experiment, and they gave a sexual virus here in Guatemala for an experiment. So we've always been used as experiments. And so they don't see us as human beings. They don't see us. And my passion here in Guatemala is because people can understand their own body. People can understand the physical part. What does my body do? How is it acting? How is it reacting? Both with medicine, chemical medicine, or traditional medicine. We're always taking something in our bodies, and we need to have a reaction. So I think that with everything that the universities and those who come here to do some studies or experiments, whether by, big pharmaceuticals or maybe testing different diseases, I believe they should explain why they're doing it, what they're doing. And for us as people to have the voice, to be heard, to be able to say, I don't want to do it, or for them to explain why. Just because they look at us and they see someone who's poor or brunette or in the mountains, they think we're going to say yes. And that's my struggle here in Guatemala. For people to understand, if they're taking an aspirin, why they're taking it. If they're taking an antibiotic, what is that going to do in their bodies? And for them to be able to be responsible of their own health, their own choices, having health. So thank you so much for this space and for... But Gonzalo, if you accept us in Bolivia, I would definitely love to be there and learn from you. Anytime. Anytime, Guadalupe. And please, you're welcome.
Gonzalo, Clare, please close us with your comments and reflections. And I love the idea of how Bolivia can help other Latin American countries who have had a different path. Thank you so much for everyone being here, and I'll let Gonzalo close.
Thank you so much, Jess. Thank you very much for the space. Thank you very much for your attention. I really appreciate it. I would like to piggyback on something that Ben said, and that's a sacred responsibility of our mission. I think that only highlights the commonality of our problems wherever we look. So we have more in common than we think. And I think that together, as Guadalupe said, I think that together we can solve them. So I think that's our mission. That should be our motto, like for us in this space right now. So thank you very much, Jess, again for highlighting, giving me the chance to address, such a really interesting group of people. I really appreciate it. Thank you very much for everything.
Thank you so much. I want to invite everyone to check out future webinars of the collaborative CFHI, and please stay in touch. And it takes a village, not to be cliche. And I encourage everyone to continue to let the world change you. Be well, be healthy. Thank you.